Hello guys, hope I'm audible and visible. If so, just say me a hi. I think I'm audible as well as I'm visible. Okay, thank you. So fine. Let's have a quick recall of the past 2 years pathology PYTs, especially with respect to INICET. So first of all, your exams are nearing, and I'm sure you must be preparing very well for upcoming INICET. There are a few things which I want to tell first before going on to the pathology section. Right? The first thing, especially in INICET, there is one golden rule which you should remember for sure is there will be questions which you will not be able to attend. They are very difficult questions which you will not be able to attend. Please ignore them, right? Fine. Hope I'm audible, right? Okay. So first rule, try to avoid negative marking. It is a very important rule, especially when it comes to INICET exam. You have 1/3 of negative markings, and every INICET exam, whatever has been happened till now, there is definitely a possibility that you will have a good number of questions which are outside the box. I'll be very frank with you. There are few questions of INICET. Once a recall comes, I need to go back to the textbook and see whether it's right or wrong, right? So that's how some questions might be difficult with regards to INICET. So keep that in mind whenever you are giving an exam. That's one important thing which I want to remember. Try to avoid negative markings, right? So second thing which I want you to remember is there are few INICET focused topics. I'm sure every teacher here at MedEd would have given you their respective view about their particular topic. So when I am going to teach with respect to pathology, I'll give you a few inputs that I feel that it might be helpful for your upcoming INICET exam, maybe in the last minute to quickly brush through things, right? So when you think at INICET, INICET is a conglomerate of AIIMS, JIBMA, PG, Chandigarh, and two tiny institutes, right? So every year, one of the institutes takes the onus and they will conduct the exam. That's why INICET exams never fall in the same pattern. 1 year AIIMS conducts the exam, other year PG takes the upper hand, other year JIBMA takes the upper hand, right? So whatever said and done, there are few important things for INICET. One thing is general path and HEMAT any day in INICET will have a higher weightage compared to systemic pathology. Systemic pathology questions do come. I'm not saying to ignore systemic pathology, but there are quite a few questions in systemic pathology which you can write and relate with overlap with your other subjects, right? For example, last year there's an INICET question, which I'm sure Dr. 𝐒𝐿𝐾 must have also discussed in the orthopedics, that a biopsy of an joint was given and asked what is the most probable diagnosis. Osteoarthritis, rheumatoid arthritis, TB arthritis, like that. So those questions can be easily solved from a clinical point of view. No one is going to take a biopsy for a few things. Right? So with a little bit of idea, okay, let's loose body presentation. With that, you'll be able to solve a little to some extent, right? But general path and hemat, I want you to focus a little bit more depth, especially hematology. In hematology, generally something which most of the students ignore is blood banking. Please don't ignore blood banking, especially if you're preparing for your any INICET henceforth, right? So because blood banking is one which you can easily score marks. There's nothing you can twist. It's either the color codes, either the protocols or the transfusion reactions. Everything is protocol based, right? There's nothing to goof up in the blood banking. Please don't ignore that, especially if you're preparing for INICET, right? In addition to that, if it's JIBMA predominant paper, you might have a little bit of questions in genetics, but keep in mind, like I said, always try to avoid negative markings. Any new rare gene, rare syndrome comes, ignore them. Don't include them so that you know don't make a mistake. Fine. So these are just the 2 points we wanted to discuss before going on to the questions. Now I'll go to the questions. These are few questions which just come in the previous past 2 papers. We'll slowly and quickly go through them, and if there is any deviation from the norm, we'll definitely be able to learn more, right? So can anyone comment on this? If anyone of you are online, the first question is a very simple question. Which of the following will have the least chances of a dry tap on a bone marrow aspiration? Anyone wants to comment? It's fine if you're wrong. That's the motto everywhere. We're going to learn, and there's no exam here, right? So A, B, C, or D. What's the right answer? Which of the following will have the least chances? I've underlined something as well for you. Least chance of a dry tap on a bone marrow aspirate, right? So I'm sure everyone must have read about dry tap. Dry tap is seen in two prominent conditions, which I'm sure you guys know. One is aplastic anemia, when there's no bone marrow at all. Obviously, when I aspirate something, bone marrow, nothing is going to come out of the bone marrow, right? Aplastic anemia is one. Second thing is myelofibrosis. When the entire bone marrow is fibrotic, obviously there'll be nothing coming out of the bone marrow, so it'll end up in a dry tap. I'll take a detour from this and I'll come back to the question again. So since in these both conditions, there's going to be no bone marrow aspirate at all. So can you make a diagnosis on a bone marrow aspirate? Yes or no? Who is online? I want to get a comment. If both of them are going to give dry tap in a bone marrow aspirate, can you make a diagnosis? Never, right? So both of them, diagnosis is always based on a bone marrow biopsy. There are two tests here, bone marrow aspirate and a bone marrow biopsy. Here, only it's going to be based on bone marrow biopsy, right? So bone marrow biopsy is the mainstay for diagnosis of aplastic anemia as well as myelofibrosis, right? Now let's go back and look at the question. Dry tap will be seen primarily in these two conditions when there's no bone marrow or the entire bone marrow is filled up with fibrosis. When I aspirate something, nothing is going to come out. So that's what we call as a dry tap, right? So if you look at these options, hairy cell leukemia, there's a chance of myelofibrosis. Because hairy cell leukemia, the tumor cells kind of go and anchor in the bone marrow, destroy the bone marrow, and results in myelofibrosis. That's one of the classical findings of hairy cell leukemia. Same with AML-M7. AML-M7 also will have myelofibrosis, right? I have two more options here. See, most of the questions you will be able to rule out two things. First two options are very, very simple. These two will definitely cause myelofibrosis. I'm sure most of you will know the fact. And now we have to narrow down what is the right answer between follicular lymphoma and chronic myeloproliferative disorder, right? Okay. So when you take follicular lymphoma, right? Follicular lymphoma, it's a lymphoma. Only when it has a metastasis to the bone marrow, I'm even considered about having a bone marrow, right? Just to add on to it, whenever there is a mets to a bone marrow, okay, metastasis of anything, be it a lymphoma, be it a carcinoma, or be it a sarcoma, right? If anything has a metastasis from the bone marrow, it goes to my from the peripheral blood or from a tumor in the lung or breast, goes to the bone marrow. It kind of triggers a response. I'm sure you must have remembered this. The hallmark of any cancer is desmoplasia, right? So when this mets happens to the bone marrow, it will automatically result in myelofibrosis. That's one of the cause for secondary myelofibrosis, right? So primary myelofibrosis is something which is idiopathic or mutation related. So this is one of the reasons for secondary myelofibrosis. So when a patient has metastasis, there's very good likely chance that patient might end up in having myelofibrosis, right? So now here, so this chronic myeloproliferative disorder, what it's CML, it's polycythemia rubra vera, essential thrombocythemia. This also includes myelofibrosis. A very minuscule part includes myelofibrosis. Apart from that, I have chronic eosinophilic leukemia, chronic neutrophilic leukemia, everything, right? So chronic myeloproliferative disorder will have myeloproliferation. There's a very, very less chance for it to have dry tap. On the other hand, follicular lymphoma, when it undergoes metastasis, can cause a secondary myelofibrosis, right? So the first three options, there is the possibility there can be myelofibrosis, and CMPDs, chronic myeloproliferative disorder, except for this entity, rest everything will not have myelofibrosis. So that will be a better answer here, right? So these questions are recall based. So if you guys have not given us a good recall, and I'm sure there might be some mistake here and there when there's a recall based bias, that's always there in any recall based questions. But if these are the options, the answer is very simple. The least chance of dry tap will be seen in case of chronic myeloproliferative disorder. In rest of the other three conditions, there is a possibility of myelofibrosis, which will definitely result in dry tap. Fine. Okay, guys. Fine. So I'm going to the next question. I want you guys to comment on this question because it's a very, very simple and a very beautiful question from my point of view. I'll just keep myself quiet for some time. I'm sure some of you guys are online. I just want you guys to comment. It's fine to make a mistake. Just type A, B, or C, or D. You have anyway 125% of getting it right. I'll keep myself quiet. Okay, let's go to the answer. Reticular fibers are not seen in the structural framework of which of the following things? I want to look at this question in a very big totality. It's a very, very good question. Like I said, it's an important question from an understanding point of view. Okay, Prasanta has gone with bone marrow. Anyone else wants to comment? First, in order to understand this question, like I said, we'll go a little bit backwards and start naming the system. See, once you name some things, you will never ever make a mistake. Once you understand some things, you will never ever make a mistake, right? There are few things called as an reticuloendothelial system, and I'm sure you must have heard of this, right? Reticuloendothelial system. Can anyone name what are the organs which comes under the reticuloendothelial system? Because all the organs which comes under the reticuloendothelial system has same the thing, right? More or less the same features. Hello, Muslim world. So reticuloendothelial system, as the name says, they will have a reticulin framework. That's one first thing, reticular fibers, and then it will have the endothelium. which means it'll have sinusoids. Okay? So when you have sinusoids and when I have reticular framework, I call that system a reticuloendothelial system. Perfect. Prasanta said that spleen and liver is a reticuloendothelial system. Again, the same question to you. Can I call bone marrow also a reticuloendothelial system? Muslim word, can you please ping me on Instagram? I'll definitely lead you to a right person to help you out. Right? Bone marrow is also a reticuloendothelial system, right? Thymus is also a reticuloendothelial system. Lymph node is also a reticuloendothelial system, right? So all of these are reticuloendothelial system. So like I said, spleen has a reticular framework plus it has sinusoids. Liver has reticular framework plus it has sinusoids. The Kupffer cells are there in sinusoids, right? So all these are reticuloendothelial system. Fine, just give me a second. So when I have anything with reticuloendothelial system, the framework should be there and I have the sinusoids, right? So all these four are reticuloendothelial system. Now comes my question that question is asking an outlier. I always say that exceptions are MCQs. So I have a reticuloendothelial system which does not have a reticular framework, right? Let's go again to the options. Lymph node, spleen, thymus and bone marrow. All four are reticuloendothelial system. I'll tell you what is a reticular meshwork means. This is how reticular meshwork looks. I have fibers surrounding every cell. Right? And I have fibers surrounding every cell. I call that a reticular meshwork. That's what actually I mean by reticular meshwork. Fibers surrounding every cell. When I have fibers surrounding every cell, is there a possibility for the cell to die? Or will it be always held upon? I have fibers surrounding every cell. Will it die or it will always be held upon? Just give me a second. It will be held upon, right? The fibers, it will not leave, it will not be destroyed, right? Perfect. Now, looking at these four options, tell me one organ system here which will disappear when I grow as an adult. Which organ system will be grow as an adult? Which will disappear when we grow? Thymus disappears when we grow, right? So which means, can I say with confidence, thymus reticular meshwork is not actually very strong? It is. So thymus is an pseudo reticuloendothelial system. Again, if next time when an MCQ comes, I want you to remember that. Now let's understand why did people name thymus as a reticuloendothelial system? Because of the function. The function of thymus is for B cell, T cell production and everything. Bone marrow, same function. Lymph node, maturation of the lymphocytes. Spleen and the liver, again, production of of the RBC, WBC places inside the body, right? In the intrauterine life, right? So all of them had the same function. So they thought it's a reticuloendothelial system and they have named it as a reticuloendothelial system. But thymus reticular meshwork is not that great. That's the reason thymus disappears. No other organ disappears here, right? They will stay back because lymph node has a beautiful reticular system. Spleen has, bone marrow has, but thymus doesn't have, right? So when you understand the core concepts, you will never make a mistake. And I'm sure here, if you learned this, next time if there's a question on pseudo reticular system, keep in mind that thymus is not a reticular system, right? It's as simple as that, right? Okay, let's go to the next question. It looks very big. Whenever there's an question which is a match the following, right? Match the following is one of the easiest one, right? Tell me what's the right answer. I'll keep myself quiet for some time. Comment on the answer. Sorry, the first one is pleomorphic adenoma. I hope it's visible now. These are the options A, B, C, and D, and you can go with it. Okay, again, present has gone with B. Others who are online, it's fine. Come out of your shell and answer the right answer. You'll be mostly right, don't worry. If you make a mistake here, believe me, you'll never make the same mistake in the main exam. Okay, let's go with, see, whenever there's a match the following, keep in mind that always go with an option or the matches which you're very much comfortable with. Because sometimes it will help us to rule out other options, right? Of these four things, I'm sure most of the students who is listening to it, or you must have read, knows retinoblastoma, which is RB. It's very, very simple, right? Most of you, I'm sure, will know Burkitt's lymphoma also. It is 𝐒𝐿. Because Burkitt's lymphoma, you have the translocation between 8 and 14. 8 is where you have the 𝐒𝐿, right? So most of them knows that as well, right? So these two I already know, which means 2 is equal to, sorry, 3 is equal to B and 4 is equal to D. So this is wrong. 4 is C, right? Okay, 3 is B, 4 is C. Possibly it's right. 3B, 4D, again wrong. 3D, 4A, again wrong. So with these two things itself, you'll be able to give the right answer. Retinoblastoma is your RB gene and your Burkitt's lymphoma is your 𝐒𝐿, which makes the other two also right. So option B is right, like Presence has said, it's the right answer, right? So pleomorphic adenoma, plaque 1, this came in one INICET. Generally for salivary gland tumors, we don't use markers. We don't use genetic markers. It's an easily diagnosable thing. You can take a biopsy or an FNAG to pick up pleomorphic adenoma. But genetics is creeping in slowly in every tumor system. Maybe in future, plaque 1 might become one of the important diagnostic protocol modality in real life as well, right? But do remember, if it repeats, I don't want you to miss. Plaque 1 is your for pleomorphic adenoma and neuroblastoma is your NMYC. N stands for neuro. MYC is the gene. The N subtype is for the neuroblastoma, right? Both 𝐒𝐿 as well as NMYC, both MYC are your proto-oncogenes. Whenever this MYC is involved, the tumors are very, very, very highly proliferating. Most of the MYC involved tumors are very highly proliferating. They divide a lot. Neuroblastoma, if you remembered your surgery classes by Dr. Sandeep, he must have definitely told that neuroblastoma is some tumor which can easily grow huge, right? And also you must have, if you remember the X-ray finding, can anyone tell me the X-ray finding of neuroblastoma? X-ray finding of neuroblastoma, because X-ray finding is one thing which is very, very characteristic, and I'll be able to give a reason for that. If you find a reason for anything, no, it excites us a lot. An infant in an abdomen X-ray with speckled calcification. Do you remember them? An abdomen X-ray with something called as speckled calcification. It's a very classical finding for a neuroblastoma, right? We'll try to understand why is an X-ray diagnostic for a neuroblastoma. This is a classical diagnostic finding for a neuroblastoma. Fine. The reason is, like I said, MYC is something which can proliferate a lot. When a tumor proliferates a lot, can I say that tumor also will die faster? Any fastly dividing things will definitely die fast, right? Because the high proliferation is a very, very high death rate as well. So whenever I have a very high death rate, what happens is, what's the most common ion seen in necrosis? We'll go back to our first chapter. Most common ion seen in necrosis is calcium, right? So whenever I have very high death rate, there's an excess of calcium which causes your dystrophic calcification. That's all. There's a very high growing tumor which has a very high death rate. That's why the dystrophic calcification or the speckled is not uniform. I have a tumor this big. I cannot say the tumor to have calcification throughout, right? I cannot say in a line cells die. I have calcification here and there. This person speckled calcification, right? So the speckled calcification, even on an abdomen X-ray, is diagnostic in a young infant, because neuroblastoma is a tumor of infancy, happens in less than 1 or 2 years of life. 1 or 2 years of life, no other tumor in the abdomen has this classical speckled calcification because of the NMYC. It's related. Whatever you see clinically, whatever you see in your lab finding will be related to pathogenesis. Just find the link. You don't want any one of us. You will definitely keep on growing further. Fine. Okay, that's about it. The right option is option B, and let's go to the next question. It's a very simple one. I want you guys to come in. Let's see how many of you can get it right. I'll keep myself quiet for some time. Whatever comes to your mind, tell me. Answer? It's a simple question. You can solve the question either with the help of the history or with the help of the biochemical findings. It's a very simple one to answer. Okay, let's dissect the question now. 30-year-old female with a history of weight gain. So when I have a history of weight gain, and if you look at the options, I have something related to thyroid, pituitary, and parathyroid. It's multiple things here, right? Parathyroid generally doesn't have anything to do with weight. Let's keep it a little bit away. And what we have is thyroid function test. So it's most likely either thyroid or pituitary, because pituitary problem also can cause thyroid problem. You know that of the control and the negative and the positive feedback which happens from the pituitary, right? Okay. So Prashant, again, a simple question to you. When you have a patient with a weight gain, hyperthyroidism or hypothyroidism? Sorry. Hyperthyroidism or hypothyroidism? It'll definitely be hypothyroidism, right? So clinically also, I have a patient which is similar to an hypothyroid state, because weight loss, when the basal metabolic rate increases, there'll be weight loss, right? So weight gain is kind of equivalent to an hypothyroid state. I have a patient with hypothyroidism. At the same time, T4 is very low, TSH is very high. So coming back to this biochemical scenario, T4 being low and TSH being high. So there's a problem in the thyroid, or the problem is in the pituitary, because I have primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism, right? That different levels at which can go wrong, right? So here T4 is being low, which means the thyroid is at stake. The thyroid gland is abnormal, and the TSH is elevated because I'm having a negative positive feedback mechanism. When my thyroid gland is not able to produce hormones, pituitary says that, okay, let me give you thyroid stimulating hormone, please function. Right? That's a feedback what you're seeing here, right? So with this, I have a hypothyroid state, which is primarily targeted due to damage to the thyroid. Of the options, so this can be easily ruled out. Completely gone. Graves again gone, because Graves is an hyperthyroid state, not a hypothyroid state. Again, this already we ruled out completely, right? So the only thing which is sticking back here is an Hashimoto's thyroiditis. It's a simple case of an hypothyroidism due to Hashimoto's thyroiditis, which is common in middle-aged female as well, right? So now, since we are in the hypothyroid and hyperthyroid state, like I said, I have primary, I have secondary. We'll limit ourselves to primary and secondary. Tertiary is something which is problem in the hypothalamus, which is kind of rare, right? We'll keep primary and secondary alone. So when I say we'll have T4 levels, we'll have TSH levels. T4, T3, both one and the same, fine? Okay. So when I have a problem in the, if TSH is low, T3, T4 is low, when TSH is high, this is primary hypothyroidism. In secondary hypothyroidism, where the problem is in the pituitary, if it's a pituitary related problem, like you might have definitely heard about Sheehan's postpartum necrosis, apoplexy, right? Post pregnancy is the probability that the entire pituitary can get washed away. So if pituitary is gone, TSH will be low. Because TSH is low, T3 and T4 is also low, right? So it's a pituitary related hypothyroidism. This is how it will be. When I compare this to hyperthyroid, again, that also you have to know. So again, if it's a primary hyperthyroid, T3 and T4 and TSH. Increased, reduced. Because the thyroid is hyperfunctioning, like in case of Graves' disease, thyroid is hyperfunctioning, producing more T3, T4. So obviously the feedback will reduce. On the other hand, I can have a TSH secreting tumor in the pituitary, like a pituitary adenoma. So there, TSH will also be high, T3 and T4 also will be high, right? So these are the permutation combinations which can come in with respect to your primary and secondary hypo and hyperthyroidism. Similarly, you can have hyperparathyroidism. Most of the organs like will have this thing, Cushing's. We have Cushing's disease, we have Cushing's syndrome, right? So there are lots of things which happens in the peripheral organ, and I can have a damage in the central organ. You need to know the biochemical things, because that helps you in the differential diagnosis, and also in real life, it helps you to focus where is the problem primarily. I can have a galactoria, problem in the pituitary, or problem in the breast parenchyma. Right? Cushing syndrome, it can be due to an adrenal cortical tumor, or ACTH secreting adenoma, or an peripheral ACTH, right? A paraneoplastic syndrome. So all of them can be asked with this. It has so many permutation combinations. You can ask good number of questions by just these values, right? Do remember them. It's an important topic, be it from path, or be it from biochem, or be it from medicine. Fine. Let's go to the next question. Let's see how many of you are able to give the right answer. It's a very simple one. I'm sure most of you must have seen this table multiple times, right? CK20 and CK7 table. Yes. Let's go to the answer. CK20 positive, CK7 negative. At least one, I want you guys to comment, then I'll definitely take it away. Okay, Prasanta's again gone for colorectal. Anyone else wants to comment? I'll just highlight what was required for me. CK20 positive and cytokeratin 7 negative. Okay, that's a very important information for me here. CK7 and CK20 is something which has been routinely done in pathology labs. That's why this question came. It's not a question which is very difficult. It's a very practical question, because when I have a tumor, especially from a lymph node, I need to, it's swelling here, supraclavicular. There's a possibility it can be from the lung. There's a possibility it can be from the GIT. There's also a possibility it can be from the thyroid. It can be from anything, right? So I need to tell the clinician, okay, see, you have to go and look at the lungs using these markers. So they'll take a HRCT of lung. Will not put an endoscope. So I'll help the clinician in not doing too many investigation. helps to focus because I already have a tissue sample, right? CK7 and CK20 is something which is very commonly used, and that's why it came in an exam. It came twice in an exam. After that, they have forgotten it, but still, I want you to remember. I'll give you not many things to remember, very simple things to remember. You remember like this: CK20 positive, CK7 negative, like in a scenario, is possible in case of an colorectal, like Prasanth said, and it's also possible in one more tumor. Please do remember them. This is not come in an exam. It might come in future. Merkel cell carcinoma is very, very important. A Merkel cell carcinoma is also very important, and it'll have something CK20 being dot-like positive, right? A dot-like positive for CK20 is diagnostic of an Merkel cell carcinoma, right? These are two things. If CK20 is positive, at the same time CK7 is also positive. Can any one of you comment? CK20 positive, CK7 positive. What are the differential diagnoses? There are plenty of differential diagnoses, but at least few of them I don't want you to forget. Both positive, 7 and 20 positive. Anything which comes to your mind? I'm not going into pancreas because pancreas is an overlap finding. Bladder is perfect. So urothelial tumors, that's one. And ovarian tumors. Like I said, I'm not going to your pancreatic cholangiocarcinoma because pancreatic cholangiocarcinoma is a variable expression. It can be CK20 positive, CK7 positive. At the same time, 7 positive, 20 negative also. There's a possibility, right? The third possibility for me is CK7 positive, CK20 negative. Any comments? I'll tell you an easy way to remember this. CK20 is something for a lower aerodigestive tract or a lower GIT. Anything below the ligament of Treats, a tumor comes, it will be lower GI. CK7 is for upper aerodigestive tract. It's just above the ligament of Treats. There are multiple things about the ligament of Treats, starting from lung. It's also above, right? Breast parenchyma, like you said, yes, it's above. Thyroid is above, right? Your esophageal, anything in upper GIT will be here. So I'm just kind of saying it's an upper aerodigestive place. Its salivary gland comes here, right? So salivary gland is CK7 positive, 20 negative. Breast parenchyma, I'll ignore breast for some time. I'll tell you why. Lung, but yes, breast also for that matter. The reason why I'm ignoring breast is, what do you think is better for breast parenchyma or breast cancer? Do you think ERPR is better or CK7, CK20 is better? Undoubtedly ERPR is better, right? So that's why I don't want you to remember breast first, but yes, that's right. Anything above, anything in the upper GIT, I'm writing UG as well. Upper GIT, like an esophagus, like your stomach, right? So all of them will fall in the same category, CK7 positive and CK20 negative. Both being negative. If both CK7 as well as CK20 is negative, I just want you to remember only one person. There are multiple things here as well. Just at least don't forget this prostatic carcinoma. I'll tell why as well to remember this. Hepatocellular carcinoma is also CK7 negative, 20 negative. I don't want you to remember because HCC, I don't take a biopsy at all in the first place. Renal cell carcinoma is also both negative. Again, renal cell carcinoma morphology is clear cell renal cell type. It's very, very easy. I don't generally go for a marker at all. But prostatic adenocarcinoma kind of can mimic most of the adenocarcinomas what you've seen. It can mimic an ovarian, it can mimic in colorectal, right? That's one thing I want you to remember. Don't forget this also. Like Prasanta said, I'll add on to it RCC and HCC. But the probability of me using them to diagnose RCC or HCC is way low compared to prostate. Don't forget prostate. If you remember RCC, HCC, I'll be more than happy for that. Fine. Okay. So if this table comes and any question in the future comes in this table, you should not make a mistake. This question came like 2.5 years back. After that, they have not repeated this question because I think the examiners also know that you guys know this table by heart, and maybe in future they'll ask one more different table. Okay. Let's go to the next question. Let's see how many of you can answer this question. It's a very, very simple one. It's actually a question which was asked like 6-7 years back and it came back again. Answer? Differential expression of genetic material is seen in which of the following conditions? Genomic imprinting, incomplete penetrance, partial penetrance, or mosaic. Actually, it's differential expression of genetic material based on gender. If there's one which you can add to it, it's based on gender, right? Okay, differential expression of genetic material based on gender is seen in which of the following? It's seen in genomic imprinting, not incomplete penetrance, right? So when I say differential expression of genetic material, let's understand what we are talking about here. So here, anyone born as a human being will have 46 chromosomes and will leave X and Y. Rest every chromosome is twice. It's expressed twice, right? So it's said that in few species, only the maternal will express. In few species, only the paternal will express. Both might not express. That is differential expression. Let's take for an example, which we already know in case of one genomic imprinting, your SNRP1 gene, right? SNRP gene or your ubiquitin 3A gene in Angelman syndrome. That's a maternal expression. That's a silence, right? So genomic imprinting is a differential expression, which means there's a gender specific silencing. Okay, this is gender specific silencing. Like present I answered, there's a possibility of doubt with incomplete penetrance because that actually follows the thing. If you look at incomplete penetrance, I say that some of the patients who have the mutation don't have the disease. Incomplete, differential expression. But when I call something as expression, it's not a disease, it's normal. Incomplete penetrance is seen in autosomal dominant disorder. It's not something seen in every patient. It's seen only in case of an autosomal dominant disease, right? So expression is something which is not disease specific. Your hair color is gray, brown, blonde. It's not a disease. It's an expression of a trait, right? So when I call it differential expression, I call it with respect to a trait, not with respect to a disease. Incomplete penetrance is seen in dominant disorders, primarily in autosomal dominant disorders. Okay, to remember that. Partial penetrance also is another name given for incomplete penetrance. Mosaics is something which is a post-zygotic error. This is also not a normal thing. This is actually an error. Of these things, only thing which is normal is imprinting. Imprinting is a normal phenomenon. Imprinting is not a disease. Because of imprinting difference, I might have different diseases. That's all. Fine. Okay, the answer here is option A, genomic imprinting, which is one of the primary reasons for Angelman pathology. That's the right answer here. Fine. Next question. It's a very simple one. The answer. It's a very simple one. And I'm sure most of you must have written the right answer when it came in an exam as well. It's a simple fish, right? So the name, the technique which is given in the image, though the question itself is not seen, you're able to tell the right answer, right? So do remember two things. This is a standard fish. This type of fish is called as an interface fish. Because here I have the entire nucleus seen. It's a round nuclei on which I have dots. There is a possibility that you can have metaphase fish as well. It will look the same, right? When you have something in cell like this, metaphase, where you have chromosomes, blue color chromosomes. When you have chromosome like blue color and red and green dots, I call them a metaphase fish, right? Generally, fish is not done in a metaphase. Which is the investigation which is done in a metaphase? Metaphase, it's karyotyping, right? Karyotyping is done in metaphase. In interface is where I do the fish generally, but I have fish in both metaphase and interface. If you have blue color chromosomes, like a karyotyping, but blue in color, that's in fish, metaphase fish. This fish, what is shown in the image, interface fish, right? PCR generally doesn't have an image. If you remember your stepladder pattern in agarose gel electrophoresis, that is PCR. Okay, that's how PCR looks like, blocks and everything. Right? The output of PCR will be like this. Fish is like this. Sanger sequencing, again, it doesn't have an image. It's more of a computer generated graph like thing. Karyotyping, I'm sure you know that, right? There are a few questions in karyotyping. Let's quickly go through the karyotyping as well. Which is the most commonly done staining in karyotyping? This also came on the exam. Most common done staining in karyotyping. It is G banding, right? G banding or an Giemsa stain. Giemsa stain is the most common stain done in karyotyping. Karyotyping is done in a metaphase chromosome. There's an older MCQ that doesn't hold any sense these days. It was previously said that fibroblast cannot be used for a karyotyping. It's nothing like that now because my technology is so advanced that I can take any cell in the body, culture that cell, make the cell divide, and I can do karyotyping, right? Like I said, there are few things in medicine which becomes obsolete over the period of time. Ignore them, right? Now I can do a metaphase arrest using the drug colchicine, which I'm sure you must have heard in gouty arthritis. Use that, stop the arrest the cell division, and align it and do a karyotyping. G banding. It's called a GIMSA banding or a G banding karyotype. That's a commonly done staining in case of karyotyping. I have C banding, centromere banding, Q banding, quinacridine banding, and reverse banding, R banding. These are the types of staining which we do for karyotyping. Fine. Okay, great. Next question. It's a very simple one. Though the IHC here is in very, very old IHC, but still it holds to some place. Comment on your answers. What's your answer? Okay, Shanta's again right. It's Ewing sarcoma, right? See, this is what I was saying about systemic pathology. When it comes to systemic pathology, any question in systemic pathology, it's not that you should always solve it from a pathology point of view. Fine. Let's dissect this question. 15-year-old, Ewing's, osteosarcoma, chondroblastoma, leukemia. Most of them are in a young age, first or second decade. So I don't have anything extra addition with the age here. Fine. Next thing for me is in diaphyseal lesion. Okay. Chondroblastoma, diaphysis or epiphysis? It's not a diaphyseal lesion, right? Osteosarcoma, diaphysis or metaphysis? Not a diaphyseal lesion, right? So these two are unlikely possibility based on the location of the lesion, right? So now a diaphyseal lesion, it could be in leukemia, lymphoma, multiple myelomas, Ewing sarcomas. Most of them are diaphyseal lesion, right? So diaphyseal lesion, which you must have read in orthopedics or in radiology, also gives me input for diagnosis. So when it comes to systemic pathology, that's your real life pathology. When they take a biopsy of a bone tumor and give to me, I don't diagnose it alone. I sit with the radiologist, I sit with an orthopedician, and then we come to a diagnosis. That's what we want you guys to do as well. It's not a pathological diagnosis. It's a diagnosis of the patient. It's always multisystemic, right? So I can rule out this. Now on microscopy, there are small round blue tumors. Yes, there's a possibility of Ewing's and leukemia. Both can have small round blue tumors. Leukemia with an extramedullary blast or lymphoma can have small round blue tumors. Next is my MIC2 positive. The older name for this is CD99. CD99 was positive in case of an Ewing sarcoma. That makes it the right answer. And leukemia is not the right answer. CD99 or MYC2 itself is a very, very, very old marker. There are lots of new marker which has come into play. If anything comes in future, I expect that at least CD99 should go outside of the undergraduate curriculum at least. So remember this. NExT 2.2. It's a reason marker which is done for Ewing sarcoma. I don't use CD99 now. I'll come to it, Prasanta. CD99, I don't use it for diagnosis at all these days. It's only NExT 2.2, right? If there, that's the marker for Ewing sarcoma. There's one more marker as well. Can anyone tell me what is the gene involved in Ewing sarcoma? Because there's a marker related to the gene. I'm sure you know the chromosome translocation 1122, and the gene involved is FLI1. So these are the two markers which are relatively new and which are much, much more sensitive as well as specific with regards to Ewing sarcoma than your CD99. Fine. Okay. FLI1. Perfect. Okay. Prasanta, coming to CD markers, it's a very difficult question to answer for me. Any CD marker which is with respect to your lymphomas, do remember them. If you find lymphoma CD marker difficult and if you have time, there's a video on B-cell's journey in the app. Just have a look at that once. It will flip your mind for initial few minutes. It will be difficult, but once you read B-cell's journey, I'm sure that you need not memorize any B-cell markers, because B-cell markers, that CD markers for your mantle, marginal, follicular, everything is logical, everything is conceptual. I start memorizing them. When I start memorizing them, there's definitely a possibility of thing to forget it. That's all. When it comes to your markers of systemic pathology, your CK720, that flowchart, these few things have been repeated. Your rhabdomyosarcoma, MyoD1, which there's a question on ophthalmology, right? Common tumor which is there in the ophthalm. Those things, please do read them because that's where systemic pathology questions do come. Fine. Next question. Okay, this is a controversial one. Let's see how many of you tell the right answer. I'll give you my answer and I'll justify why that is right as well. Again, all these are PYQs. Just look at the image and come to the answer. Your answer? Maybe if you want to zoom the image, I'm sure you're able to see the image here. Which of the below this epithelium is not seen in which of the following? Fine. The question is very simple and straightforward. I'm seeing an epithelium here. Where don't I see the epithelium is the question. Okay. Can I say everyone here accept it's a ciliated epithelium? Yes. It's a ciliated epithelium, right? It's definitely having cilia. Okay, perfect. In this photograph, can you say it's a stercocilia or a normal cilia? Can you say it's a stercocilia or normal cilia? Because that's one thing which you remember read in histology, the difference between stercocilia and normal cilia. Moves, doesn't move, the organization, dynams and everything. You cannot say it's a stercocilia or normal cilia. It's a brush border, that's all. That's a cilia, that's all. That's the only information I can see here, right? So epididymis has stercocilia. I'm right. Everyone is right in calling it a stercocilia. But in a photograph, no one will be able to differentiate as a stercocilia or a normal cilia, right? So epididymis also will look the same. It will be a ciliated epithelium. That's it. Fine. Oviduct is your fallopian tube. Oviduct also has a ciliated epithelium. It's a fallopian tube. Fallopian tube will definitely have a ciliated epithelium, right? Bronchus, pseudostratified. If you look at this image, can I say that this pseudostratified? It's pseudostratified. Every nucleus is one on top of the other. It looks like stratified, but actually not a stratified, right? That also has cilia. Ependymals, on the other hand, they are non-ciliated. Okay, they're non-ciliated. So the right answer for this epithelium, where in the image I'm seeing a cilia, is an ependyma. Ependyma is not a ciliated epithelium. Rest everything is cilia. If the question comes, which is cilia and not stercocilia? This is a stercocilia. Fallopian tube and bronchi are cilia. Do remember them. And epididymis, I'm sure you know that it's a stercocilial epithelium. Fine. So the right answer here, I would go first ependyma and not epididymis. First three options will have cilia in the microscope. In a microscope, in a HNE, I will not be able to differentiate the cilia or stercocilia. Fine. Okay, that's my take on this, because I know that there are few controversies around this question. I'm not going into that part basically. Fine. Okay, let's go to the next question. The answer. It's a simple one. This is an important one as well. I'll tell you the clinical importance of this once we solve this question. Because this, every surgeon might be required to know this, especially when you start evaluating patients for surgery. Yeah, President is right. The answer is simple. So the clotting factors is not seen, will not affect clotting in vivo, right? It's just factor 12, which means if you remember your Guyton, right from the day of Guyton, we always used to draw like this, right? An intrinsic pathway, extrinsic pathway, common pathway. Actually, inside my body, it's not intrinsic, extrinsic, or common. It's just a single pathway of clotting cascade. That's all. It's intertwined between intrinsic and extrinsic. For our understanding of PT and APTT and to diagnose, we draw this flowchart, the Y-shaped thing. Y-shaped thing is actually not in vivo, it's in vitro. This is how it happens outside the body. Inside the body, it's always mixed. Starts with factor 7, goes to factor 9, factor 10. It gets help of everything and then goes to the common pathway, right? But if you remember the intrinsic pathway, it starts with factor 12. Here I have factor 7, right? Can anyone comment here which of the clotting test will assess the intrinsic pathway of coagulation? PT or APTT? For intrinsic pathway, it is APTT, right? Activation partial thromboplastin time is for my intrinsic pathway. I'll just write intrinsic. And your PT, prothrombin prime, is for an extrinsic pathway of coagulation, right? Okay, perfect. So, like I said, this is not a one-liner. This is not an MCQ. For me, the application of this question is more important than the question per se, right? So, factor 12 is not involved in the clotting cascade inside the body. But am I right in saying that when I do an APTT, which assays intrinsic pathway of coagulation, will factor 12 be assayed or not assayed? It will be assayed, right? It'll definitely be assayed, right? So let's say I have a patient with factor 12 deficiency. Okay, this is a very important concern for me. When a patient has a factor 12 deficiency and I'm going to do an APTT test, will the APTT be elevated or normal? It will definitely be elevated, right? Obviously, APTT will be elevated, right? Obviously, it will be elevated. At the same time, looking back this question, factor 12 is not required for my in vivo clotting cascade. So when a patient has factor 12 deficiency, will there be any symptom of bleeding? Will there be any symptom regarding bleeding or failure of clot formation? Will there be or no? There will be no symptom. So factor 12 deficiency will be asymptomatic. So why I said every surgeon should know this is because before surgery, you will ask for an PT-APTT assay, a bleeding time, clotting time, to see that there is no problem in the coil. There's a routine test done. No symptom for the patient of bleeding, no trauma from the nose, no cut injury, nothing there. But APTT alone is elevated. Please remember, it could be a factor 12 deficiency. Don't think it's a lab error because there's a dysynchronous here between the symptomatology and the lab test, because factor 12 is not involved in vivo clot formation, but when you do a test that's APTT, it starts with factor 12. This is a very important combination which I want every future surgeons to know. Remember this, don't miss this out at all. Fine. Okay, we'll go with one more last question because I think charge is going out. Okay, comment on this question and we'll wind it up by this. We'll definitely learn more things together in future. Comment on the answer. Which of the following is not a feature of pleomorphic adenoma? It's a very simple question. Squamous epithelial pearls. Okay. Fine. We'll look at this option. We'll read all the four options and then we'll go to the answer. Fine. Squamous epithelial pearls, myoepithelial cells, chondroid areas, and perineural invasion. Fine. Let's go to your exam. Like in your final year of MBBS, you must have definitely seen patients with pleomorphic adenoma. You must have presented also, right? In a pleomorphic adenoma, will there be involvement of facial nerve? Yes or no? Pleomorphic adenoma is a benign tumor, right? It's not a malignant tumor, it's a benign tumor. Do you think benign tumors will have involvement of facial nerve? Generally, no, right? Benign tumors don't have involvement of facial nerve, right? So, which means perineural invasion is a feature generally of a malignancy. Facial nerve involvement in clinically means I know it's a malignant tumor, right? I won't have involvement of facial nerve in a benign tumor, right? So, pleomorphic adenoma will not have perineural invasion. Adenoid carcinoma will have, mucoepidermoid carcinomas will have, right? Any carcinoma or malignancy of salivary gland will have perineural invasion. A benign tumor that is pleomorphic adenoma will not have, right? Now let's see, what does pleomorphic adenoma mean? It's not actually pleomorphism, it's polymorphous. I have multiple population. I have both epithelial and I have mesenchymal tissue. This epithelial tissue can be myoepithelial cells, can be cuboidal epithelium, can be squamous epithelium, because the ducts of salivary gland are made of squamous epithelium. So squamous epithelial pearl is seen in case of pleomorphic adenoma. Myoepithelial cells is seen. Okay, so the right answer here is your my is not so good now. Right answer for this question, we'll wind it up here, is perineural invasion. Perineural invasion is not a feature of pleomorphic adenoma. Rest everything, your squamous epithelial pearl, your myoepithelial cell, as well as the chondroid lesions are classically seen in case of pleomorphic adenoma, right? I just want to add one more thing. Pleomorphic adenoma can become cancer. When it becomes cancerous, we call it carcinoma X pleomorphic adenoma, which is carcinoma arising from a pleomorphic adenoma. Just do remember them. And the most common cancer coming here is in squamous cell carcinoma, right? So we'll wind up the session. That's all for today. And all the very best for your upcoming INICET exam. And I'm sure you will do well. Rock the exam. Don't be afraid of making an error before the exam. And in the exam, read the questions carefully. Go a little bit early. I'm sure the admit card will be out soon. And we'll be more than happy to look at the recall session on the same day of the exam. Fine. See you all there, and all the very best from my side. Thank you. Bye bye.